And welcome back to Health Watch. Been talking to Dr. Ray Dugan about some wrist injuries and approach to wrist injuries, and we were at the point where potentially you could do arthroscopy, which I think is just fascinating. We talk about arthroscopies of some of the big joints and what can be done and actually looking in a joint, and you don't really think of a wrist as something you can look into, but you can.
You can. It's a much smaller joint, obviously, so technically it's a little different and has its own difficulties. Wrist arthroscopy has not been nearly as popular as shoulder and knee arthroscopy, but certainly has gained huge popularity as we've learned more about it. What we do with the wrist arthroscopy is it's a surgical procedure. The patient goes to the operating room, they're under anesthesia. We support the arm in a way that there's some traction applied to the wrist, so that allows some of these bones to just sort of gently separate a little bit so that we can put a small scope into the joint. One of the things also that's different about a wrist is that you can't see the whole wrist just through one little poke hole. You really need to make multiple little holes to get in there and put the scope in different compartments of the wrist in order to be able to visualize the different compartments. It's really pretty fascinating when you put the scope into the wrist how much you can see. You can see the articular surfaces, you can see whether the cartilage is smooth or whether it's worn down or damaged. You can really see all of the ligaments and see whether or not they're even just a little bit stretched, maybe not necessarily torn in shreds, but even just a little stretch you can appreciate arthroscopically. So once you've done a complete examination and have determined what the pathology is, we've developed, as we've gone by, a lot of arthroscopic treatment also, where we can sometimes smooth down a little damaged cartilage area, or if there's a ligament that's been stretched but not completely torn, we can shrink that ligament, tighten it up by using a small radiofrequency wand. We can take out ganglion cysts from the wrist. They're the lumps that you often see on the top of the wrist that are filled with fluid.
We don't hit them with books anymore? I thought we eliminated them. That's okay.
So instead of making a big incision that often ends up with a kind of an ugly scar, we can do them arthroscopically and it's barely noticeable later. We can do procedures where we shorten this ulna bone. There was a condition that I would like to talk about at some point called ulnar impaction syndrome, where this ulna bone is too long and it can rub on the other side of the wrist. Basically, this bone rubs against the carpal bone called the lunate, and the cartilage can get damaged and cause continued pain. The standard operation is to make a big incision here, take a wafer of bone out of this ulna, and then put a pretty large plate and screws on it, and then cast while it heals. But there is an arthroscopic technique that that is good for certain patients, where we just go in basically with a little Dremel type burr and trim off a couple millimeters from the end of the bone and can achieve the same effect. We also use arthroscopy to assist in fracture treatment. We put the scope in, look at the fracture, and make sure that it's lined up properly, and maybe instead of making a big incision, we can just put some percutaneous screws in through some small incisions. So it's added a huge amount onto our ability to treat some of these wrist problems with less invasive techniques.
Yeah, that's fascinating. And again, the advances that we've seen in the optics are just fascinating, from the large scopes that we were used to using when we first came out to what they're able to do now, and the capabilities. That's a great advancement. We'd be remiss if we didn't talk about carpal tunnel. It's a common complaint. People think they have it, don't have it, they're overtreated, undertreated. And we have about 4 minutes. Just explain what is carpal tunnel syndrome, and then what is the treatment?
Well, I can show on this model. This is the palmar side of the hand and forearm, and the yellow is the median nerve, which runs underneath this structure here called the transverse carpal ligament. It's a very thick ligament that basically holds the tendons in place, and the nerve runs with those tendons. Sometimes it just gets too tight in there, the nerve gets pinched, the electricity can't flow across the nerve, and then it can cause pain in the wrist, up the forearm, into the fingers. It can cause numbness, tingling, and these muscles here at the base of the thumb are worked by this nerve, and sometimes those muscles become weak, or they can actually atrophy away, where you see this big sunken in area. So In the very early stages, what we recommend is brace treatment at nighttime. If that doesn't take care of the problem, then we recommend surgery. Typically, the standard operation in the past has been a fairly large incision where we would go all the way down the palm and maybe even across the wrist crease. Then that gradually got smaller and smaller. Then there was an endoscopic procedure that's been developed. There's pros and cons with the endoscopic technique. It is a small incision, but there is some increased risk of injury to the nerve with that procedure, and also a risk that the ligament might not be completely released and the symptoms might persist. What I think that we've really learned from endoscopic carpal tunnel releases is that you don't have to do this big incision. You can do it through a small open incision. I use a mini open approach. The procedure actually takes 5 minutes. It's closed with 3 stitches, and I find the results to be excellent with carpal tunnel surgery. I think the key is that you don't want to wait too long to get it done. We find the results are best in patients who've had carpal tunnel for less than 3 years. If they start getting permanent damage to the nerve, then they don't really get a full recovery, and that might be the patient who says, I had carpal tunnel surgery, but it didn't work. Of course, you have to make sure it's the correct diagnosis and that we're not dealing with some arthritis condition also that could also be mimicking carpal tunnel.
Right. The fingers that are mostly involved, you're talking about thumb and index finger?
Traditionally, it's the radial 3.5 fingers, the thumb, index, middle, and this portion of the 4th finger. But the anatomy can vary. There are variations in how the nerves supply the different areas.
Right. And I've heard people complain, you talked about a little bit up the forearm, it's been misdiagnosed and, as shoulder pain or whatever else. What do you see sometimes?
It can radiate all the way up to the shoulder. I've even seen patients come in with scapular pain and it turned out to be their carpal tunnel. That's much less common. Very commonly, it will radiate to the elbow and even cause lateral elbow pain. Typically, it's worse at nighttime. Patients wake up. They're often shaking their hands like this. Sometimes when they're driving or talking on the phone, the symptoms are aggravated also.
Yeah. I'm just fascinated with the fact that going back to our previous conversation, I would have swore we were going to have all kinds of recommendations about work injuries, particularly working with computers. But from what you're telling me, the computer, it's not really one of the causative agents for carpal tunnel.
No, it's not considered that way anymore.
Yeah.
One of the things that I think is important for carpal tunnel patients when we examine them is to check their strength. There are a couple maneuvers that we do. One is to have them pinch their thumb to the 5th finger. And it's amazing how many people will come in and can't do that, and they never realize that. And then you try to pull apart, and it's very weak. It'll just give way. Another maneuver is to have them abduct their thumb like this and then push it towards the other fingers. And a lot of times it just gives way. And again, they didn't necessarily realize those patients need surgery.
Yeah, and the fact that they could have some permanent neurological or functional damage if it's not diagnosed early enough.
Right.
Ray, it's been fascinating. I think some of the advancements in our wrist surgery, particularly, is just fascinating. Our approach to it, as in many other different disease states, and we look forward to seeing what else comes down the road as we talk about our joint replacements, particularly. I can just see us sitting here talking about joint replacing your wrist someday, and
we have that.
Yeah, well, that's another topic. We don't have the time to do it.
Yeah.
Thanks for coming, Ray.
Sure thing.
Thanks for watching Health Watch.